Good afternoon, dear colleagues. So the setting of this problem is quite unusual. We speak about pragmatic trials, about using RWD. But, you know, we're trying to connect it with the clinical recommendations, and that helps us understand what will happen in the near future. But globally, I would like to say that we have an understanding that on the basis of clinical recommendations, we will build a unique for our country and for the entire world, a unique system. Medical system. It will allow to keep an eye on the patient's journey, what happens to the patient starting from examination to the drug therapy. It also creates an opportunity to make very high quality registers on important nosologies. Speaking about clinical recommendations, it is a very large step that was made by our community, headed by the Ministry of Healthcare and professional associations. Of course, professional associations were to develop very important documents in a very short time. And clinical recommendations today are formulated as instruments for the solution of various tasks. They are based on the federal law. Here I would say that help create standards. Here I would like to say that clinical recommendations are becoming a universal instrument for doctors. And since they are renewed not less than each 3 years, we get a very strong influence of recommendations on the routine clinical practice, because clinical recommendations always have a section about quality control. And since I am a member of the Council on Recommendations, I have to go through very many recommendations from different professional communities and from, you know, that very many different communities participate in the development of recommendations. I would like to focus on the fact that all clinical recommendations I have seen have a section devoted to the treatment and reaching certain targets, certain indicators, qualitative and quantitative, that are obligatory in making this or that interference. So we understand that on the one hand, the renovation is periodical. The schemes of drug prescription are very tough. For example, now we are making an upgrade of clinical recommendation on cardiovascular diseases, where we will declare that if the ejection fraction is reduced, the patient will get tripartite therapy, and if it is not provided to the patient, the doctors will have to answer why it has not been done. The same about arterial hypertension. If the blood pressure, the target blood pressure is not achieved, doctors have to explain why they have failed to do it. So of course it will affect our medical practice to a great extent. And a year ago, the ambulatory records of patients that were under the real-world data observation and they determined the target of arterial hypertension, and only 8% of patients achieved the target of 130/80 blood pressure. And that was a very serious case. The same when we studied cardiovascular diseases, new types of drugs were introduced, but the full therapy was observed only by 12% of the patients out of 1,000 that were under observation, under investigation. That's why it is that all these cases will be taken into account when the recommendations are being developed. You see that today over 300 clinical recommendations have already been approved, 13 on cardiology, 3.5% of the total number. But I would like also to speak about the following aspect. It is not enough to accept clinical recommendations. You know, foreign sources give us a figure of 10-20 years for the new clinical recommendations to become routine practice. In this case, I am an optimist, and I think that the control over clinical recommendations on the level of the medical institutions will shorten this period. But today, clinical recommendations have turned from the auxiliary instrument into the main regulation of practical work and are used for the control and judicial assessment of the specific doctor's activities. So all those approaches in the clinical recommendations will affect the modern schemes of therapy, and they become basis of the routine work. As to pragmatic clinical trials, their number is growing in the entire world, and it started in 2017-18. We are the hostages of the situation when we assess the efficacy of different interferences, and we understand that despite the fact that we follow tough standard rules, good clinical practice, but let us ask ourselves a question. Have you seen many trials on hypertension where the average age of the patients was below 60? No, there are very few. But there are very many patients below 60 with the problem. But if we take all the people, our results will be more significant. In order to receive the same result in the group with a lower risk, we will require much more years. You remember whole 3 trial when 7 years were required to reach endpoints. You understand that it is a great financial load on pharma companies. But another question arises, how can we extrapolate the results of our trials received in ideal clinical conditions to the clinical practice? Will the technologies that were effective in patients over 60 be effective for patients under 60? But it can be proved to become evidence-based. And here we see a very good and clear scheme of the positive expected effect and the negative expected effect. Now, this is a recent example that we will remember. Take, for example, a large group of drugs for obesity, dextroamin, that was used quite actively, and there were very serious adverse effects, and it just left the market because of that. The newest examples, there was a drug used for the treatment of ischemic disease. Posicur, it also left because of side effects, and we have very many examples like this. And for example, the class of drugs which we hoped for effective, the nicotine-like receptors, Remonaban-like drugs, but they proved unsafe from the point of view of cardiovascular system. Or, for example, thiazoline, neons, rosiglitazone. Rosiglitazone was compromised in the conditions of real clinical practice because there were very many cases of heart failure. So you see, clinical trials and clinical practice have very great differences, and here we have to say that the conditions of the clinical trial, in the clinical trial, it is impossible to foresee all the side effects that may arise. Now we have two terms, real-world data and real-world evidence, and we understand that real-world evidence includes pragmatic clinical trials. The works that appeared, which is called Introduction to the World of Real Clinical Trials, that appeared in 2021, it showed that real-world data are the results that received from the patient and in the system of real health, and real-world evidence is the clinical evidence about the usage and potential benefits or risks of a medical product. Pragmatic clinical trials are important. This is one of the tasks of our medical community. It is important to popularize this area because it can become unique for our country, because today we will have certain limitations in the work with Western CROs, but our own trials, well planned, based on pragmatic solutions, are much cheaper, and the appearance of these registers will allow us to get very good information. There are advantages and disadvantages of this method, and this is the slide that I show for the first time. In order to get real-world data, we need the things that we didn't do before. Look at the electronic health records. We, do not analyze the accounts of territorial compulsory medical insurance, and we should do it. We understand that these compulsory medical insurance instruments are not used fully. Registers of diseases, registers of drugs. As to registers of diseases, we know they will work very well with orphan diseases, but for socially important, significant diseases, these registers do not work so well. As to registers of drugs, we know what it is. For Spinraza, for example, each patient is accounted for. Of course, we underestimate the data of the patient's self-control or patient-generated data. including in the home use settings, because we lack equipment here to provide all patients with the equipment for self-control. And of course, it means the analysis of a very large mass of data. Here you see the characteristics of data collection in classical and pragmatic clinical trial. As an example, I would like to show how our foreign colleagues work with real world data. So here you see CGLT2 inhibitors and see how the population conforms to these trials. It is quite evident that here we have a lot to think about. These are examples of how trials are conducted. Our Indian colleagues have their own national program of pragmatic clinical trials, and they conduct very many pragmatic clinical trials whose results have been published. One more important trial in diabetology, they compare different classes of drugs, and we see that for many positions, new classes of drugs have a more expressed perception. What was not done during double-blinded, they didn't compare GLT2 head-to-head, but the results of clinical trials on the pragmatic scenario proved the sulfonylurins are bad. We see how bad they are. We know that SGLT2 receptor is better than the other. It also shows the degree to what degree it is better. And this is quite an innovational drug for the compensation of acute heart failure, very key GUAT, but in 2022, you see the results of the trial that was made for very key GUAT in order to introduce this drug to the market. We see that real clinical practice of its use is very close to the data of the patients that were in the Victoria trial. I would like to say that today the pragmatic clinical trials are a scenario of the influence on the real clinical practice. They take up an interim position between observational and basic, well-planned, randomized trials. I would like to show respect to Professor Kolbin and his respect, who do a lot in order for RWD, RWE become a part of our everyday practice.